Hello everyone and welcome to the first lecture in the topic of arrhythmias in our ECG course. In order to understand what we are going to do in dealing with arrhythmias in ECG, we are going to have specific lectures for bradyarrhythmia and then for tachyarrhythmia. In each topic of them, we are going to start with a lecture regarding the classification of this type of arrhythmia, and then we are going to have a specific dedicated lecture for each type of these arrhythmias. And today, our lecture is classification of bradyarrhythmia, which is in an important preamble before going in depth with the bradyarrhythmia as the sinus node dysfunction and AV blocks. Of course, bradyarrhythmia is one of the very common situations that we see in the ER, and so today we need to learn the scheme for classification of bradyarrhythmia in order not to interpret any ECG as just bradycardia without identifying the specific cause of this bradycardia and to learn the different mechanisms of bradyarrhythmia. And of course, we should note that we are not talking here about the acute or long-term treatment of bradyarrhythmia, and also this is the situation in dealing with tachyarrhythmia, because in this course we are focusing on the ECG diagnosis, not on the management. And in order to understand the ECG diagnosis, of course, we need to understand the mechanisms and the types. So we need to give a short resume regarding the conductive system of the heart. I know, of course, that we explained this diagram before in the lectures of bundle branch blocks and intraventricular conduction disturbance, but of course it is very important for us to understand our lecture today. Of course, we know that the normal pacemaker of the heart is the SA node, which lies in the right atrium in the subepicardial region, and of course it is the normal pacemaker of the heart because the highest rate of pacing is in the SA node, and that's why it takes the upper hand and it overrides other ectopic foci inside the heart. From these SA node arise the internodal tracts, which transmit the impulse from the SA node to the AV node, and of course we know that there is a Pacman's bundle that transmits the impulse from the right atrium to the left atrium, and so atrial depolarization takes place. Then the AV node is like the transition between the atria and the ventricles, in which the impulse are transmitted from the atrial chambers to the ventricular chambers. Then arises the His bundle, which passes inside the interventricular septum and bifurcating into the right bundle branch and the left bundle branch. And of course, we know that the left bundle branch itself bifurcates into the left anterior fascicle and left posterior fascicle, and finally, all these fascicles bifurcates into multiple smaller branches called Purkinje fibers, which are responsible for delivering the impulse to the ventricular muscle fibers to cause ventricular depolarization. So this is in summary the conductive system of the heart that we are dealing with today in order to understand the bradyarrhythmia. Of course, when we mention the word bradyarrhythmia, I mean any abnormal rhythm with heart rate below 60 beats per minute. At that time, I can call this bradyarrhythmia, regardless the type, and that's why we need to understand the types and various types of bradyarrhythmia. And this is completely different from the terminology intraventricular conduction disturbance, which is like a conduction delay or blockade in the intraventricular conductive system at a certain point or a certain location, starting from the bundle branch till the Purkinje fibers, regardless the heart rate. This means that intraventricular conduction disturbance can take place and the heart rate is above 60, and sometimes the heart rate may be below 60. So presence of intraventricular conduction disturbance, like which we discussed before in two lectures, like left bundle branch block, right bundle branch block, left anterior fascicular block or left posterior fascicular block, doesn't mean that the heart rate should be bradycardic. No, it is different. So these two terminologies are different from each other. So intraventricular conduction disturbance, they include left bundle branch block, right bundle branch block, intraventricular conduction delay, left anterior fascicular block, left posterior fascicular block, bifascicular and trifascicular block. Let's deal today with the bradyarrhythmia because this is what we are paying attention to today. Bradyarrhythmias regarding their mechanisms are divided into two main mechanisms: disorders in impulse generation and disorders in impulse conduction. Disorders in impulse generation, this means that there is disorder in the SA node, because the SA node is responsible for impulse generation because it is the normal pacemaker of the heart, and so we can call this a disorder in the SA node. And disorders in impulse conduction means that there is a problem in the conduction of impulse from the atria to the ventricles, and so it is a disorder in the AV node. And so we can use other two specific terminologies in order to describe these disorder, which are sinus node dysfunction, or which was famously called sick sinus syndrome, which was a classic term to describe them. But of course, sinus node dysfunction is much a broader and much more common used term at the time being, and AV blocks to describe the disorders in the AV nodes. So we understand now the two main mechanisms for bradyarrhythmia, which classify them into sinus node dysfunction and AV blocks. But what can cause bradyarrhythmia? In order to have two main etiologies for the bradyarrhythmia, we can divide them into two main titles. The first title is the degenerative title or pathology, and the other type is the secondary causes that may cause AV block apart from degenerative pathology. And of course, this term of secondary bradyarrhythmia has a lot of different etiologies below it. So let's start with degenerative disease. Of course, we know that degenerative disease occurs usually with advancing age, and so it is more common in the old age. And it includes fibrosis and sclerosis of the conductive system, which are the most common causes of acquired conduction system disease. And that's why most patients with sinus node dysfunction or AV block, most of them are caused by degenerative pathology, which of course it is an irreversible pathology that accounts for approximately half the case of AV blocks, for example, in adults, and also may account for sinus node dysfunction. And progressive cardiac conduction defect, like for example Lev disease or Lenègre disease, manifests as progressive slowing of the electrical conductive system through the atria, AV node, his bundle, Purkinje, and ventricles, and eventually it may lead to complete AV block that may manifest as syncope, and in some cases, if neglected, may lead to sudden death. So let's start, for example, by sinus node dysfunction. First time when I see that there is a problem in the SA node manifested in the ECG in the form of sinus bradycardia, for example, or sinus ptosis, at that time I need to exclude secondary causes at first. Like what? Of course, the first secondary causes I need to exclude iatrogenic causes caused by medications like beta blockers, non-DHP calcium channel blockers, digoxin, amiodarone, and ivabradine, as all of them slow down the heart rate. And of course, we need to exclude other causes like coronary artery disease, like high vagal tone in athletes, like during sleep, like hypothyroidism, like vasovagal syncope in the cardioinhibitory type, Cushing reflex, and severe hyperkalemia. All of this may lead to sinus node dysfunction, so we need to exclude them. And of course, regarding during sleep, at that time, I mean not just 12 lead ECG, I mean for example Holter ECG. If you see severe form of sinus bradycardia in the Holter ECG, you need to check whether the patient was asleep at the time or he was awake. So these are the secondary causes that I need to exclude. And if these secondary causes are excluded at that time, I think of degenerative pathology causing the sinus node dysfunction, and at that time I can decide that the patient has no etiology explaining sinus node dysfunction apart from degenerative pathology. Let's now talk about AV blocks. Of course, when we talk about AV blocks, of course, the most famous type is the degenerative AV block, which usually occurs in the old age, and this is the most common form or most common cause of AV blocks that we usually see in the ER, like Lev disease or Lenègre disease or other forms of degenerative pathology. Of course, there are other causes like drug-induced, the same medication, beta blockers, calcium channel blockers, digoxin, amiodarone, and even ivabradine. There are some case reports regarding occurrence of AV block with ivabradine. Other causes may include inferior STEMI, which is a very famous cause of AV block, even to cause third-degree AV block, because of course we know that the AV nodal branch arises in 80% of cases from the right coronary artery, and so it is very common to see AV block in patients with inferior STEMI, and usually it is reversible because it usually correctable after perfusion of the culprit artery. Hypothyroidism, also an extreme condition, may lead to AV block. Although it is not very common, you may see sinus bradycardia with hypothyroidism, not very common to see AV block. But of course, in extreme cases like in mixed edema crisis, it may lead to this, and so you need to exclude it, although it is not a very common cause. Also, severe hyperkalemia in the advanced stages, it may lead to AV block or may lead to some sort of escape interventricular rhythm, and so I need to exclude hyperkalemia in patients with AV block. Post-operative is a reason for causing AV block, like for example after aortic valve surgery or VSD closure, because the aortic valve is very close to the AV node, so during the replacement surgery it may lead to injury in the AV node. Sometimes it is reversible in the first 7 days after surgery, but sometimes it is irreversible and the patient may need permanent pacemaker. And after ablation procedure, sometimes when we are performing AV-NRT ablation or anteroseptal accessory pathway ablation, this region may be close to the AV node that they may lead to damage of the AV node. It may be reversible at the first few days, and sometimes it's irreversible, needing permanent pacemaker. And there is a famous cause, although not very common, of course, in our country, but it is one of the documented causes in literature, which is Lyme disease, which is a bacterial infection caused by Borrelia organism, and it may lead in advanced stage to heart block. So we need to understand what is meant by these two terminologies, Lenègre disease and Lenègre disease. Lenègre disease is caused by proximal calcification in the bundle branch or sometimes fibrosis, and so it is described as senile degeneration of the conductive system that appears in old age with hypertension, atherosclerosis. And so it can manifest at first time with bundle branch block, but it can manifest as well by second degree or third degree AV block, because there is a problem in the AV in the His bundle and sometimes in the bundle branches themselves. So this is Lenègre disease. Lenègre disease also is another degenerative disease that occurs usually in younger populations than Lenègre disease, and it involves the more distal portions of the bundle branch, and so it is more common to cause intraventricular conduction disturbance rather than heart block. We have also another entity causing AV block, which is a loss of function mutation in the sodium channels. In this diagram, we can see the action potential in the ventricular muscle fibers, which is a sodium-dependent cells. And of course, we are going to deal with the action potential in detail in another lecture regarding the ECG in electrolyte disorders. And so, in this form, we see that, of course, sodium influx is responsible for phase 0 of the action potential. Sometimes inactivating mutation causing partial closure of the sodium channels may lead that the action potential is slowed down, and so this leads to slowing down of conduction in the heart. So in this diagram, which was designed, of course, by my professor Dr. Osama Diab, who passed away 2 years ago, and so I send him all my greeting because this lecture is dedication to him. Here I can say that there is normal sodium channel function in which the normal depolarization occurs in the ventricle, but here there is like partial closure of the sodium channels, and so the conduction is slowed down, and so in the AV node at that time the conduction may be slowed down, leading to heart block. So also another pathology occurs here, which is dystrophic calcification, in which there is calcification of the aortic valve or the mitral annulus, which is very common finding in old age in the echocardiography. And this calcification may extend to the His bundle as it passes adjacent to the fibrous continuity between aortic and mitral valves, and so it may involve His bundle and it may involve left bundle branch. And so dystrophic calcification, which occurs in old age, may be a reason for heart block. Of course, we should not forget that heart block is not only a disease of old age, it may be a disease also that appears in infants or children, and this is called congenital AV block, which is present since birth, but not all children manifest with this bradyarrhythmia, and during childhood, sometimes the child may survive till adults and it is not discovered because of symptoms, but it is just discovered accidentally in an ECG, and sometimes the child may be symptomatic since birth. So here, for example, the most common cause for congenital AV block that should be excluded is maternal systemic lupus, in which there is vertical transmission of anti-Rho and anti-lung antibodies, causing damage to the AV node in the fetus, and this may manifest after birth. At the time, it may lead to severe form of bradycardia that may need correction. And congenital heart disease that is commonly associated with congenital AV block, like congenitally corrected TGA and common AV canal, and that's why echocardiography is very important in any child with congenital AV block. Loss of function, as we explained, of the sodium channels in the AV node can be a cause for congenital AV block, as we explained in the last slide. Also, cardiac tumors like rhabdomyoma, which is the most common benign tumors in children, may be a cause for congenital AV block because it causes mechanical compression of the AV nodes. Storage disease like Fabry disease or amyloidosis may lead to congenital AV block, and of course laminopathy, which is a form of dilated cardiomyopathy caused by lamin AC mutation, may cause congenital AV block. So, of course, in dealing with any patient with AV block, don't forget to exclude secondary causes like drug-induced, like infused STEMI, like hypothyroidism, like severe hyperkalemia, like post-operative post-ablation or Lyme disease. And if all secondary causes are excluded at the time, I can decide that this AV block is due to degenerative pathology. And this is very important before deciding whether this patient needs permanent pacemaker or not. If this arrhythmia is caused by secondary causes that may be correctable, or it is an irreversible pathology that cannot be corrected, and so I can think of whether this patient would need permanent pacemaker or not. And near the end of our lecture, we need to understand an important terminology which is called escape rhythm. Of course, as we understood in the first slide regarding the conductive system of the heart, that SA node is the dominant pacemaker of the heart that overrides the whole heart. And so sinus rhythm is a dominant rhythm because the sinus nodes produce impulse with the highest rate, so taking the upper hands apart above all ectopic foci inside the heart. And sometimes the escape rhythm occurs when SA nodes produce the fail impulse, or the AV node fails to conduct. So another focus in the heart takes over the duty, and so the ensuing rhythm is called escape rhythm. So escape rhythm arises when the SA node fails to produce its function, and here I'm not just speaking about slowing down, but sometimes I'm speaking about, for example, sinus pause or sinus arrest, and so another escape focus in the heart takes the upper hand in order to save the patient. And also in case of that the SA node is intact but AV node cannot conduct the impulse to the ventricles, another focus below the AV node takes the upper hand in order to pace the ventricles. And of course, many different foci in the heart can produce regular impulse to depolarize the ventricles in order that the patient would have a heart rate and a pulse. And for example, as we know, SA node is the highest rate of a pacemaker, and that's why it is the normal pacemaker or the dominant pacemaker of the heart, as its heart rate is usually 60 to 100 beats per minute. But atria can act as escape foci, causing an atrial escape rhythm, but it is below 60. AV node also can act as escape focus that can pace the ventricles at a heart rate of 46 beats per minute, and the ventricles are the slowest foci that can pace the ventricles at a rate of 20 to 40, which is called idioventricular rhythm. So escape rhythm, of course, is like a manifestation of an original disease, and so the disease process that causes this escape rhythm is more important than the escape rhythm itself. So please don't just diagnose that the patient has escape rhythm, but you should try to search for the cause for this, whether it is sinus node dysfunction or complete AV block, which can be understood from the ECG, as we are going to discuss in the next two lectures. So we have two main types of escape rhythm. Escape junction rhythm, in which the bradycardic rhythm arises from the region of the AV junction, which is usually the AV node in case of sinus pause or complete AV block. And it is usually, of course, narcomplex because the downward conduction passes through the ventricles through the Hesper-Purkinje system, and so it is rapid conduction, and it is a stable rhythm that is less liable to pauses, so we are not afraid of escape junction rhythm. But we are afraid of escape idioventricular rhythm because it is a bradycardic rhythm, usually at a heart of below 50, but usually it may reach below 40, as we mentioned, that the ventricles have the slowest traced rate in comparison to the SA nodes, the atria, or the AV nodes. And this rhythm arises from the bundle branch or the ventricular muscle fibers themselves in case of infrahisian complete AV block or sinus node dysfunction. And it is usually wide complex because downward conduction passes through the ventricular muscle fibers, and it can show left bundle branch block or right bundle branch block according to the origin. If it is arising from the left ventricle, it would show right bundle branch block morphology and vice versa. And it is, of course, an unstable rhythm liable to pauses or asystole. So whenever I see a patient with escape idioventricular rhythm, at the time I should rush to inserting a temporary pacemaker, because in a second this patient may develop bradyasystole and he will develop sudden cardiac death. So escape idioventricular rhythm is a more dangerous escape rhythm than escape junction rhythm, which is a more stable rhythm. So at the end of our lecture today, we understand now how to classify bradyarrhythmias in general, and we understand the mechanisms of bradyarrhythmia, like disorders in impulse generation, which is causing the sinus node dysfunction, and disorders in impulse conduction, which is causing the AV blocks, and we understand the notion of the escape rhythm. And of course, our take-home message today: record the ECG during any bradyarrhythmic episodes for documentation purpose and also for making a session plan, because sometimes the bradyarrhythmia is intermittent. So once you record it with a 12-lead surface ECG, it is very important to document what is the cause for this patient symptom, which may make a decision whether this patient may need a pacemaker, need a change in his medication, or need conservative treatments. And of course, check for secondary causes before deciding that the bradyarrhythmia is due to degenerative pathology. So please, before deciding this AV block is irreversible or the sinus node dysfunction is an irreversible condition caused by degenerative pathology and the patient should go for permanent pacemaker, for example, according to its degree, please exclude secondary causes at first before deciding it is degenerative pathology. And of course, in the next 2 lectures regarding bradyarrhythmia, we are going to discuss sinus node dysfunction at first, and then the second lecture would be dedicated for AV blocks. Thank you very much for your listening.